Hello guys, welcome to the Parson series, and today we'll be doing part 2 of chapter number 4. So last time we discussed about the neurology of the brain association with the vision. Today we'll be focusing on pupillary pathways and the reactions. So in the pupillary pathways and the reactions, we know that the pupils are controlled by two muscles which are of ectodermal origin. So our focus will be the two muscles, the sphincter pupillae and the dilator pupillae, right? Now, the responses to these muscles to the stimuli are very rapid and delicate, and they are easily observed. The size of the pupil may be looked upon as essentially the result of the opposite forces, because the forces which are acting through the sphincter pupillae and the forces which are acting through the dilator pupillae, literally they are opposite. Okay, so whatever, it's just like a tug of war. Whoever is winning is the real effect that is given. The innervation of these muscles will be seen in the figures. The constrictor center, they possess a tone and it is perpetually sending out the impulses. These impulses are going to the sphincter, which keeps the pupil slightly contracted. Abnormal enlargement of the pupil is called as the mydriasis, and abnormal contraction is called as meiosis. So you know this. Okay. Now this is actually the pathway. They have tried to show the various pathways. You have got the excitatory pathway, you have got the inhibitory pathway, the different centers they have shown. The parasympathetic pupillary system, okay, they have shown. And along with this, they have also given the parasympathetic pathway, that is your Edinger-Westphal nucleus, the third nerve, inferior division, that is the branch to the inferior oblique muscle. That is your inferior division of the third nerve. Then you also know the light reflex, it is going through ciliary ganglion, the short ciliary nerves, and that is finally ending into the sphincter of the iris. We also have the near reflex, the accessory ganglions. Okay. Now, if you look at the parasympathetic pupillary system, we have got three things here. One is your cortical control. So they are going, you know, excitatory pathways are coming from the frontal as well as the occipital system. And then you also have the inhibitory pathway. This is going from the frontal cortex, and there is one more system called as the sympathetic control, inhibitory. So inhibitory is coming from hypothalamic. So I think this you may be knowing from your neurology. We can summarize this, that you have a excitatory pathway. Excitatory pathway is coming from your frontal as well as occipital, and then you have got the inhibitory. This inhibitory is coming from the hypothalamic center. This is coming from the hypothalamic center or your hypothalamus. In this way it is going on, right? Now if you go to the nerve supply of the pupillary muscles, so what are the muscles that we have and what is their nerve supply? The sphincter is actually supplied by the cholinergic nerves of the parasympathetic system, and they are operating through the third cranial nerve. And that is why when the parasympathetic system operates, we have got the constriction of the pupil taking place. The fibers, these are actually starting in the Edinger-Westphal nucleus near the third nerve, and this is lying in the floor of the aqueduct of Sylvius. Now this nucleus has connections with the dilator center as well as with the frontal as well as occipital cortices, and the fibers emerge from it. They pass out of the midbrain to run in the main trunk of the third nerve. Now here the fibers pass into the branch. Which branch? The branch which is going through the inferior oblique and leaving it through the short route of the ciliary ganglion. So they are telling you the whole pathway in such a descriptive manner. From the ciliary ganglion, they are passing by the short ciliary nerves, piercing the sclera around the optic nerve, and then finally they pass forward in the choroid and the ciliary body to the iris. So how actually this whole of the nerve stimulation takes place, how it is ultimately going to the pupillary muscles, how we have the two systems working together, the sympathetic and the parasympathetic, and here they have explained to you the parasympathetic, ultimately how the innervation is going up to the sphincter of the iris. Now, if I talk about the dilator pupillae, the dilator pupillae is actually supplied by the adrenergic fibers of the cervical sympathetic nerve, and these dilator tract is actually starting in the hypothalamus. Okay, and though it is starting from the hypothalamus, it is also connections with the cerebral cortex. So this is again an important thing, that though it is starting from the hypothalamus, but it is also having the connections with the cerebral cortex. So this is the same thing that they have shown you with the help of this picture. We have got the different systems here. We have got the hypothalamic center here. Then we have got the different ganglions, superior cervical ganglion, middle cervical ganglion, then annulus, and then this is your inferior cervical ganglion. So basically they are trying to show you what is the total pathway that this sympathetic as well as the parasympathetic pathway and the fibers are going on. Now from this hypothalamic center, okay, what is happening? From this hypothalamic center, we also have the dilator fibers which are passing downwards, and then they are passing through the medulla oblongata. From this medulla oblongata, they are going into the lateral column of the cord. Now these fibers, when they are passing through the cord, they leave the cord by the ventral roots of the first three dorsal and also the two cervicals. So we have got the three dorsal and then we have got two cervical, they are passing through, and then ultimately they are going into the thoracic or stellate ganglion. Now from this thoracic or the stellate ganglion, they are passed through the anterior limb of the ana of Wiossens. So what is this ana of Wiossens? In this, actually in this nerve, they run up the neck to the superior cervical ganglion, from where they pass along with the carotid plexus into the skull. Okay, and then they run over the anterior part of the Gasserian ganglion. They pass through into the first or ophthalmic division of the fifth nerve, following the nasal branch. Then they are passing through the long ciliary nerves, and thus what they are doing is avoiding the ciliary ganglion. Now these long ciliary nerves enters the eye on each side of the optic nerve, accompanying their arteries also, and then these long ciliary nerves, they will run forward between the choroid and the sclera. They enter the ciliary body and ultimately they reach the iris. Okay, they are passing through between the choroid and the sclera. They enter the ciliary body and they ultimately reach the iris. Okay. Now, if I talk of the balance of the balance of the tone between these two antagonistic innervations, they maintain the pupil at its normal size. So, how actually they are able to maintain the pupil at its normal size? Because you know, you have got two opposite forces working every time. So what is there? We have got a essential factor, that is your superior tone of the sphincter. The two pupils are normally equal on both sides, okay, and like we have got a term where the size of the pupil is different on both the sides, and that term is your anisocoria, but it is very rare to find normally that we have an anisocoria and you have got the different size of the pupil in a normal person. But you know, every time you are getting this, you should actually try to eliminate some pathological cause for that. On the other hand, the size of the pupil varies widely in the different pupil under the same conditions. Now, it's very rare to have the different size of the pupil, like the two pupils of the same person behaving in a very different manner in under the similar condition. But yes, it is very common to see that the different pupils of the different people behaving differently when they are having or they are exposed to same levels of illumination. Okay, now the pupils are smaller in the older people than in the young, and sometimes to the extent that they are almost pinpoint. So these are your normal physiological variations. Like in older people, you are getting very small pupil, pinpoint pupil. In the young, they are comparatively larger. They are often smaller in the hypermetropes and they are larger in myopes in comparison to the emetropes. They are also smaller in blue eyes than in brown eyes. So a lot of man-to-man variations are there. Now talking about the pupillary reflexes, the pupils participate in several reflexes and they are important also. Like one is your light reflex, one is your near reflex. If I talk about the light reflex, light enters the eye and pupil constricts. This is your light reflex. So in the same eye, it is the direct. In the same eye, it is the direct light reflex, while if I talk about the other eye, then it is the consensual light reflex. Now I talk of the near reflex. What is this near reflex? So when a person is seeing a near object, looking at a near object, then also contraction of the pupil takes place. And what happens, that this is called as a near reflex. But what happens when you are bringing the object very, very near, then even the accommodation also starts taking, whenever you are bringing the object very close, then the accommodation also starts playing a role. That is why they are saying that this is largely determined by the reaction to convergence, but in which accommodation also plays a part. So mostly I can say that if I talk about the near reflex consists of convergence, mainly the convergence reflex, but a part of it can also be modified by the accommodation, and that will be called as the accommodation reflex. Then the third kind of reflex that we have is the psychosensory reflex. Psychosensory. So here you have got two parts. One is your psychic and one is your sensory. Psychosensory means we have got one is the psycho and another is the sensory. This is called as a psychosensory reflex, in which due to this you have got the dilatation of the pupil. Now another important thing is your light reflex. We'll talk about it in detail, that this light reflex is actually initiated from rods and cones. You know, they are the end receptors throughout the retina, and the fibers from this rods and cones, they'll be going up into the optic nerve. They will be decussing in the chiasma. They will be entering the optic tract. Exactly the same distribution as we were having. Okay. Now, from that, you know, instead of running to the lateral geniculate body, this we know that the light reflex pathway does not include the lateral geniculate body. Rather, it has got a small pretectal nucleus. From this pretectal nucleus, again, you will have the EW nucleus. From EW nucleus, the constrictor fibers via the third nerve, they are going to the iris, so that you already know. So, one important thing is that you do not have the lateral geniculate body, but you have that pretectal nucleus. So the same thing has been shown in the diagrammatic view also. Now, decussation. If I talk about the decussation, here decussation is important because it explains the mechanism of consensual as well as direct reaction to light, and also accounts for several pathological reactions such as the Argyll-Robertson pupil. So here they are talking of the decussation because from each pretectal nucleus, the impulse is going to the EW nucleus of both the sides. So that is actually the basis of the decussation, and how the stimulus is reaching up to the level of both EW nucleus, and why we are getting actually the consensual light reflex. Okay, now it is obvious from a study of these parts that if I have a lesion which is distal to the chiasma, then that will abolish the direct reaction in the eye on the affected side, and also the consensual reaction on the other side, right? Now, if I got a lesion in the optic tract, then that will produce a hemianopic reaction involving both the eyes, whereas the blindness due to a lesion which is affecting the visual pathway in or above the lateral geniculate body will leave the pupillary reactions unaltered. Now, another important thing is, if you remember, I told you that the pupillary reflexes are not affected when the lesion is taking place at the level of the lateral geniculate body or above, because you know the optic nerve is finally synapsing in the lateral geniculate body. So we do not get the optic atrophy, we do not get what you called as the pupillary reactions altered whenever you have a lesion in or above the lateral geniculate body. Why? Because the optic nerve fibers are synapsing there. They are the fourth order neurons there. It is also obvious that if one sees, if the one eye sees, another is blind, stimulation of the first by light will elicit the consensual light reflex in the second, provided the reflex mechanisms in the midbrain and third nerve are intact. So what they are saying, that even if one eye is seeing and other eye is blind, so if I am stimulating this eye, so this eye will not give me the direct reflex, but this will give me a consensual light reflex, because that pathway is intact there. Minute examination of the pupil when the intensity of the light entering the eye is altered shows that the pupil contracts and then oscillates rapidly, finally settling down into a condition of contraction. So we have got two different kind of exaggeration of this oscillatory response. The oscillatory response that you are going to get, okay, if you look at the examination of the pupil, then what they are saying is that pupil contracts and then oscillates rapidly, finally settling down into the condition of contraction. So in its sudden response, what is happening? Pupil is going in the opposite direction. So it looks as if it is oscillating. So two different kinds of exaggeration of this oscillation are met with the abnormal conditions. One is the condition in which oscillations are very, very large and to great extent independent of the light which is falling on the eye. This is actually called as the hippus. This is actually depending upon the rhythmic activity of the nervous centers and not a peripheral phenomena. Okay, this is actually found in cases of the multiple sclerosis. More important is the lack of sustained contraction under the continued influence of light. Now, what they are saying that here the pupil contracts sluggishly when the intensity of the light is increased. Okay, when I am increasing the light intensity, then it is contracting very, very sluggishly, but slowly dilates. This is often superimposed with the sluggish oscillations while the light is kept constant. So this is not normal, obviously, when you are having these kind of responses, and this is a pathological phenomena which is dependent upon diminished conductivity in the afferent pathway of the light reflex. So what happens, if you remember what we read in the optic neuritis, we have got the decreased amplitude, or we have the reduced amplitude of the visual recovery. Why? Because the same thing that they are saying, that here you are having the sluggish oscillations when the light is actually kept constant. So there is a pathology in the afferent pathway of the pupillary reaction. So due to that, you are getting a very, very sluggish and slow activity, and usually you get in cases of the lesions of optic nerve, that is your optic neuritis. Then another reflex is your near reflex. Near reflex is actually a combination of three effects. You have convergence also, you have accommodation. Now whenever we are converging, it leads to the constriction, so we have meiosis, but a part of it is affected by accommodation, as I always say. So because when you are bringing the object very, very close, it will stimulate accommodation. So I will have convergence, accommodation and meiosis. And because convergence is done by the medial rectus, so we have medial rectus muscles. From these muscles, they will be going up with the third nerve. What is the nerve supply of this? Third nerve. Okay, from this third nerve, it is going to the mesencephalic nucleus of the fifth nerve, to a tactile or pretactile region, because still we do not know what is the exact center for the convergence. So it is going to some tactile or pretactile area. From here, then it is again going to the Edinger-Waspel nucleus, which is the nucleus of the third nerve, and finally going to the sphincter muscle, which is actually responsible for the constriction of the pupil. So this is actually your pathway of near reflex. At the same time, accommodation reinforces the reflex by the visual impulses which are relayed from the cortex to the Edinger-Waspel nucleus. So you have got separate pathways for the light reflex, for the accommodation reflex, as well as for the convergence reflex. Then we come finally to the psychosensory reflex. Psychosensory reflex is actually the one which is initiated by the stimulation of any sensory nerve to the extent which is causing pain or emotional stress. So if you have any kind of psychic condition which is actually strong enough to initiate the pain, or it is causing the emotional state, any kind of excitement, then it is a called as a sensory reflex. And this sensory reflex, okay, this is involving both the dilator as well as constrictor centers in its production. So they are causing a rapid dilatation of the pupil. Okay, first it is causing rapid dilatation of pupil due to the augmentation of dilator tone. Whenever we have emotional stress or something, there is actually sympathetic pathway working. That is why dilator pupillae will work, and we have got sudden dilatation of the pupil. And then you have got a more sustained second dilatation, which is rapid in onset but slow in disappearance due to the inhibition of the constrictor tone. So what they are trying to say, that whenever we have the psychosensory reflex, we have dilatation, but that is occurring in two phases, the first phase and the second phase. The first phase is the one which is actually a rapid one. This is rapid dilatation. But if I talk about the second dilatation, this is rapid in onset, but this is slow in disappearance, because this is not due to the dilatation of the dilator pupillae, due to not the effect of the dilator pupillae, rather it is due to the inhibition of the constrictor tone. So first is due to the dilator pupillae, and second is due to the inhibition of the constrictor pupillae, and finally you get a long sustained dilatation. So Finally, we come to the summary, the sensory apparatus of the eye. So I can say the sensory apparatus of the eye is connecting to the brain via the visual pathway. This is very, very important, that actually if I talk about the sensory apparatus of the eye, it is connected to the brain somehow. Now, occipital cortex will be the main visual center, and it is also connected to the visual association area, sensory information transmitted from the eye. It is also traversing through another path to the midbrain, and this midbrain is responsible for the pupillary light reflex. So, a thorough understanding of the pupillary pathways and the pupillary reactions is of great clinical value in diagnosing different diseases based on the clinical presentation. So, whenever we have neuro-ophthalmology, pupillary reactions and their abnormalities play an important role. Nevertheless, we know this. So, whenever we read the visual pathway, it's always important to read the visual reflexes too. So, I think this is completing your chapter number 4, quite an important one, where the neurology is being integrated with the ophthalmology along with the radiology. And if you are able to understand this, take my words that you will be having a better understanding of the neuro-ophthalmology, neuroanatomy, neuroradiology, neurosurgery, as well as the neurology. Thank you, and happy ophthalmology.